if you're watching a medical drama on TV and a new mother starts to hemorrhage, you know the drill.
Oh, yeah, classic hospital scene.
Right. You wait for the monitor to beep, her blood pressure drops, and then the whole room panics.
Right, the alarm goes off.
But, I mean, human biology is just far more deceptive than television.
Yeah.
By the time that blood pressure actually drops in real life, she hasn't just started bleeding.
No, not at all.
She's already lost, like, up to 40% of the total blood volume in her body.
Which is just a terrifying statistic.
It really is. And welcome to today's deep dive. It is Saturday, April 25, 2026.
Glad to be here.
Today, we are drawing on some incredibly detailed medical texts, specifically Clinical Management of Postpartum Complications by Rhonda K. Lanning.
It's a fantastic, really comprehensive source.
Yeah, and our mission today is to venture into this fascinating, highly active, and sometimes really perilous medical window, the days and weeks immediately following childbirth.
Because society and, well, even our own natural instincts tend to focus purely on the newborn.
Right, the baby arrives, everyone cheers.
Exactly, the cameras come out. The assumption is that the main event is over.
But it's not.
No. For the mother, her body is just beginning this incredible systemic marathon of physiological shifts. So today, we're going to connect the dots between these severe medical emergencies and the broader picture of maternal care.
Really looking at the actual mechanics of what happens under the hood.
Exactly.
And we should probably start with the most immediate risk right after birth, the one that drives that 40% statistic you mentioned.
Postpartum hemorrhage.
Right. PPH. Now, the American College of Obstetricians and Gynecologists recently standardized how they define this, didn't they?
They did, yeah. It is now defined as a cumulative blood loss of 1,000 milliliters or more, or bleeding with signs of hypovolemia within 24 hours of birth.
Okay, and hypovolemia, that just simply means a dangerously low volume of blood circulating in the body, right?
Exactly. And that standardization across both vaginal and cesarean births is just a massive step forward for patient safety.
I can imagine.
But the challenge has always been, well, how do you actually accurately measure that blood loss in the chaotic environment of a delivery room?
Because historically, the medical field just relied on visual estimation.
Yeah, they did. Providers would literally look at the amount of blood on the drapes or the pads and just try to eyeball the volume.
I mean, I suppose visual estimation is terrible because human beings are just naturally bad at judging volume when a liquid is spread across the surface.
Oh, we're awful at it.
Plus, that blood is mixing with amniotic fluid, right? Making the puddle look much larger. Or maybe it's being absorbed differently depending on what the pads are made of.
Which is exactly why relying on the naked eye leads to dangerous underestimates. And underestimating delays life-saving treatment.
So what's the standard now?
The current standard of care is QBL.
Which is?
Quantification of blood loss. This is a rigorous physical accounting. The medical staff literally place blood-soaked pads on a scale and weigh them.
Wait, they weigh them right there in the room?
Right there. The universally accepted conversion is that 1 gram of weight equals exactly 1 milliliter of blood volume.
Wow.
They also meticulously measure the fluids collected in suction canisters, and they're carefully subtracting any irrigation fluids that the surgical team used during the procedure.
So it turns this subjective guess into a hard, objective mathematical equation.
Exactly.
Okay, let's unpack this. Because the reason this immediate accounting is so critical really comes down to the staggering amount of blood moving through the uterus.
Yes, it's an immense volume.
The text describes the body of the uterus as a basket weave of strong, interlacing, smooth muscle bundles.
I love that description.
And weaving all through those muscle bundles are these massive maternal blood vessels. During pregnancy, a huge portion of the body's cardiac output is funneled directly there to support the placenta and the fetus.
Right, and when the baby is born and the placenta separates from the uterine wall, it leaves behind what is essentially a massive, nutrient-rich open wound on the inside of the uterus.
Just a giant internal wound.
Yeah. And the biological mechanism to stop those massive blood vessels from just pouring blood into the uterine cavity, it isn't a traditional scab.
No.
No, it relies on that basket weave muscle physically clamping down.
I was thinking about this, and it's almost like a self-wringing sponge.
Oh, interesting.
Yeah, if you have a sponge soaking wet with water, and it just sits there, it leaks continuously.
Yeah.
But if the sponge aggressively wrings itself out, it pinches off all the little pockets of water.
Yeah.
In this case, if the sponge, the uterus, doesn't wring itself out tightly, those massive blood vessels just remain wide open.
A self-wringing sponge is the perfect way to visualize it. In medical terms, when that sponge fails to wring itself out, we call it hypotonia or uterine atony.
Uterine atony.
Right. The uterus remains flaccid, or what we call boggy, instead of becoming this firm, contracted ball of muscle.
And that's bad.
Very bad. Uterine atony is the absolute leading cause of early postpartum hemorrhage.
And mechanically, I mean, it makes sense that certain conditions make that atony more likely. Like, if the uterus was overdistended, stretched far beyond its normal capacity because of twins, or a very large baby, or polyhydramnios.
Polyhydramnios, yes, which is just extra amniotic fluid.
Right. The muscle fibers are stretched so thin, they simply lack the recoil to snap back.
Precisely.
So I'm trying to picture this in a chaotic delivery room. If the provider realizes the sponge isn't wringing itself out, they perform firm fundal massage, right?
Yes, they physically massage the top of the uterus through the abdomen to stimulate the muscle.
But if that manual massage isn't working, I mean, you can't just keep pressing forever. There has to be a pharmacological backup.
Oh, there is. The pharmacological backup involves uterotonic medications, and they are administered rapidly.
Like what?
Well, the most common is synthetic oxytocin. It's delivered continuously through an IV to force the muscle to contract.
And if that doesn't do the trick?
Then, providers use medications that act like chemical clamps. Misoprostol, which is a synthetic prostaglandin, or methylgonavine, which produces intense, sustained uterine contractions. They also utilize tranexamic acid, or TXA.
Now, TXA doesn't make the uterus contract, right?
Correct. Its job is to actively prevent the body from breaking down whatever blood clots it has already managed to form.
Okay. And if the chemical clamps fail, the text outlines mechanical interventions that manipulate the physics of the uterus.
Right, like the Bakri tamponade balloon.
Yeah, they insert a specialized balloon into the uterine cavity and just inflate it with fluid, which applies direct outward physical pressure against those bleeding vessels, essentially pinning them shut.
Exactly. Or they use the JADA system, which kind of flips the physics around.
How so?
It uses a gentle internal vacuum to suck the walls of the uterus inward, forcing the muscle to collapse on itself. So it's essentially doing the wringing out for the body.
That is incredible.
Yeah.
But if clamping that uterus down mechanically or chemically doesn't work, the body is going to take matters into its own hands.
And this brings us right back to that terrifying 40% statistic. The localized bleeding issue in the pelvis suddenly escalates into a massive systemic crisis, and that is known as hemorrhagic shock.
And here's where it gets really interesting. Because, like we said, we always see doctors on TV waiting for the blood pressure to drop.
Right.
But if we wait for that here, she's already lost nearly half her blood.
Exactly. Because the maternal body is executing this brutal evolutionary triage. It is designed to protect the most vital organs at all costs.
So what's actually happening?
When significant bleeding begins, the adrenal glands immediately flood the system with catecholamines.
Okay, catecholamines. Those are powerful stress hormones.
Yep. And their job is to cause the blood vessels in the skin, the lungs, the gastrointestinal tract, and the kidneys to fiercely constrict.
So the body is essentially shutting off the valves to the less critical areas, diverting whatever blood flow is left directly to the brain and the heart.
You got it. So the blood pressure reading on a cuff might look completely normal because the body is squeezing the pipes so tightly to maintain that internal pressure.
So the early warning signs aren't on the monitor at all.
No, they are highly subjective. The mother might complain of seeing stars.
Oh.
Or experiencing sudden dizziness and nausea. Her skin becomes cool, pale, and clammy.
Because the blood has literally been shunted away from the surface of her body.
Exactly. By the time the compensatory mechanisms fail and the blood pressure actually plummets, she is in an advanced stage of shock.
Which is terrifying.
It is. And to pull her out of it, the treatment protocol is incredibly aggressive. Providers use a 3-to-1 rule for fluid resuscitation.
3-to-1.
Yes. For every 1 milliliter of blood lost, the team infuses 3 milliliters of 5E crystalloid fluids.
And crystalloid fluids are essentially solutions of water and dissolved minerals, right? Like lactated ringers or normal saline.
Correct.
They're designed to rapidly expand the volume of fluid in the blood vessels, keeping the pipes full so the heart actually has something to pump, while the team initiates massive transfusion protocols for packed red blood cells and plasma. But to measure if this resuscitation is working, they don't rely solely on blood pressure, do they? They look at urine.
They do look at urine because the kidneys are one of the very first organs to have their blood supply cut off by those constricting catecholamines.
Ah,
During a hemorrhage protocol, a catheter is inserted, and the medical team is looking for a continuous urine output of at least 30 milliliters per hour.
that simple metric is the most objective, real-time gauge that systemic organ perfusion has been restored.
Exactly. If the kidneys are making urine, it proves they are receiving oxygenated blood again.
It's an astonishingly efficient biological defense system. But this leads us directly into a bizarre paradox of pregnancy.
The clotting paradox.
Yes, the body is so desperate to stop bleeding that it overcompensates, creating a completely different life-threatening vulnerability. Because the body knows that childbirth inherently involves a massive vascular wound, it naturally shifts into a hypercoagulable state during pregnancy.
Meaning the blood becomes vastly more prone to clotting. What's fascinating here is this biological tightrope. This hypercoagulability prevents you from bleeding to death, right? But it creates the perfect environment for venous thromboembolism, or VTE.
Which is blood clots forming inside the vessels.
Yes, specifically deep vein thrombosis, or DVT, usually forming in the lower extremities.
Down in the legs.
Right. And the ultimate danger is a pulmonary embolism, where a piece of that deep vein clot breaks off, travels through the heart, and lodges in the pulmonary artery, physically blocking blood flow to the lungs.
And having a cesarean birth nearly doubles the risk of VTE
It does.
because it involves major abdominal surgery, significant vascular trauma, and a period of immobility afterward. But diagnosing a DVT right after birth sounds like trying to hear a whisper at a rock concert.
That's a great way to put it.
The body's normal postpartum background noise completely drowns out the warning signs of the clot.
Right, because the classic symptoms of a DVT in a non-pregnant patient are unilateral leg edema swelling and just one leg warmth, pain, and tenderness.
But if you consider a woman who is in her third trimester or just delivered a baby, swollen, aching legs are practically a universal baseline.
Exactly. If you are listening to this and you've ever been pregnant, you know exactly how universally swollen your lower extremities get.
Right, which is exactly what makes spotting this complication so difficult.
Yeah.
The text notes that up to 90% of suspected DVT cases in pregnant or postpartum women turn out to be false alarms.
90%. Because the symptoms are almost indistinguishable from normal physiological changes. But because the risk of a fatal pulmonary embolism is so severe, medical teams cannot dismiss those symptoms.
They have to check every time.
Every time. They must use compression ultrasonography to physically look inside the leg veins. And if they find a clot, the treatment is immediate anticoagulant therapy, blood thinners.
Which feels entirely counterintuitive.
Yeah.
You're giving a patient who just experienced a massive bleeding event and who has a dinner plate-sized internal wound a medication to actively stop her blood from clotting.
It sounds wild, but it's necessary.
They use IV heparin or oral warfarin. I was actually curious how a breastfeeding mother could safely take heavy blood thinners. But the text explains that the molecular size of these specific anticoagulants is too large to cross into breast milk in significant quantities.
Right, making them generally safe for the newborn.
But still,
it requires meticulous monitoring. You're deliberately walking the patient back across that biological tightrope, suppressing the body's natural defense mechanism because the clot has become the more immediate threat.
And this isn't just a 24-hour tightrope either. We focus heavily on the immediate aftermath, but the text points out that late postpartum hemorrhage can happen up to 12 weeks after birth.
Yes, the timeline extends much further than most people realize. Late hemorrhages are frequently caused by subinvolution.
Involution being the process of the uterus returning to its normal, non-pregnant size.
Correct. So subinvolution is when that process stalls. The muscle fails to fully contract and heal.
And the underlying cause of that stall is often retained placental fragments, isn't it?
Very often, yes. Even a tiny piece of tissue left behind attached to the uterine wall prevents the surrounding muscle from clamping down entirely.
Creating this constant slow bleed that can suddenly escalate weeks later.
Exactly. And subinvolution can also be driven by pelvic infections, which have very specific diagnostic criteria.
Right. A postpartum infection is officially defined as a fever of 1.4 degrees Fahrenheit or 38 degrees Celsius occurring on 2 successive days.
Yes.
But notably, that criteria strictly excludes the first 24 hours after birth.
The exclusion of the first day is crucial. Because the sheer physical exertion of labor, combined with the dehydration that naturally occurs, can easily cause a temporary spike in body temperature.
It is the physiological equivalent of running a marathon.
It really is. But if a fever persists into day 2 or appears suddenly weeks later, providers begin hunting for specific bacterial intruders.
The most common being endometritis, an infection of the lining of the uterus itself. And mechanically, it makes perfect sense why this happens. That placental attachment site we talked about is a massive, nutrient-rich, open wound. If labor was prolonged, or if the amniotic sac was ruptured for a long time before delivery, bacteria from the lower reproductive tract have hours to slowly migrate up into that perfect breeding ground.
And the risk is significantly higher after a C-section because the sterile uterine cavity is directly exposed to the operating environment.
Wow, yeah. Another severe infection to monitor, particularly for those who are breastfeeding, is mastitis.
Right, and this is far more than a simple surface infection. It is fundamentally driven by milk stasis.
Meaning the milk just isn't moving.
Exactly. If milk isn't fully drained during feeding, it backs up in the breast ducts, causing intense inflammation. If bacteria from the baby's mouth or the mother's skin enter through a cracked nipple, that stagnant, sugar-rich milk becomes an ideal culture medium.
And it presents with severe flu-like symptoms, spiking fevers, and localized red, painful tissue.
It can be incredibly painful.
So, beyond the threat of infections, the text dives into structural anomalies that range from increasingly common to shockingly rare. Placenta creta syndrome is one of the anomalies on the rise.
Yes, unfortunately.
In a normal pregnancy, the placenta attaches to the superficial lining of the uterus. But in a creta, the placenta literally invades the uterine muscle.
Right. There are varying degrees to this invasion of creta, increta, and percreta based on the depth of the penetration. In the most severe cases, the placental tissue grows entirely through the uterine wall and attaches to adjacent organs like the bladder.
Just grows right through it.
Yes.
And the incidence of this is rising directly alongside the rising rate of cesarean births. I was trying to figure out the physiological link, and the text suggests it has to do with scarring.
It does. The scar tissue from a previous C-section creates a structural weakness or an altered cellular environment in the uterine wall.
So in subsequent pregnancies, the new placenta essentially seeks out that vulnerability and roots itself far too deeply into the muscle fibers.
Exactly. And because it is embedded directly into the muscle rather than the superficial lining, the placenta will not naturally detach after the baby is born.
So what happens if they try to remove it?
Any attempt by the medical team to manually remove it tears the highly vascular muscle bed wide open, causing uncontrollable hemorrhage.
Oh my God.
Managing placenta accreta often requires a planned cesarean hysterectomy, removing the entire uterus with the placenta still inside just to save the mother's life.
So what does this all mean? I mean, as severe as accreta is, the text outlines another structural anomaly that forces you to confront the sheer mechanical forces at play during birth.
Uterine inversion.
Yes.
I was reading this and trying to picture the physics of it. The uterus literally turns completely inside out.
It does.
The fundus, the top of the organ, collapses in on itself and pushes down through the cervix. In a prolapsed inversion, a large red mass protrudes up to 12 inches outside the body.
It is exceptionally rare, occurring in perhaps 1 in 2,000 to 1 in 20,000 births, but it represents a catastrophic obstetric emergency.
I can't even imagine. The sudden anatomical displacement causes profound neurogenic shock and immediate massive hemorrhage.
And the most alarming part is that one of the primary causes of uterine inversion is a mechanical error.
Excessive traction on the umbilical cord.
Right. If the medical provider pulls too hard on the cord before the placenta has naturally let go of the uterine wall and the uterus is currently boggy and relaxed, they are literally pulling the inside of the organ out.
Exactly. And fixing it requires a massive coordinated response. Providers must instantly initiate fluid resuscitation for shock.
And what about the uterus itself?
They sometimes have to administer medications to intentionally relax the uterus even further, allowing the physician to physically punch the organ back into its correct anatomical position inside the pelvic cavity.
Literally push it back in.
Yes, and once it is replaced, they immediately flood the system with oxytocin to clamp the muscle down so it doesn't invert again.
Wow. I mean, you cannot be Googling drug dosages or debating the next steps when an organ turns inside out or when a mother has lost 40% of her blood volume. It requires absolute precision.
If we connect this to the bigger picture, this is exactly why standardized management protocols are so vital.
Right.
The text highlights patient safety bundles created by organizations like AIM, the Alliance for Innovation on Maternal Health.
They implement hemorrhage carts pre-stocked with every uterotonic medication, Bakri balloon, and instrument we've discussed today.
Right. They establish massive transfusion protocols that bypass normal blood bank delays.
It is all about removing human hesitation. Regular emergency drills ensure that the response to a boggy uterus, or the subtle signs of hemorrhagic shock, is instinctual and uniform across the entire healthcare team.
It transforms individual medical heroism into reliable systemic safety.
It really does. We've covered a staggering amount of physiology today, from the intricate basket weave muscles acting as a self-wringing sponge to the deceptive hide-and-seek of the shock cascade,
The double-edged sword of hypercoagulability.
and the creeping mechanics of late-stage infections.
The postpartum window is just a highly volatile period of physiologic recalibration.
Yeah.
For you listening, whether you are a parent, plan to be one, or simply support friends and family who are, understanding these mechanisms is empowering.
Absolutely.
Knowing that seeing stars isn't just exhaustion, that aching legs shouldn't be dismissed as normal swelling, or that bleeding weeks later isn't just a heavy period.
That specific knowledge shifts our societal focus from exclusively caring for the newborn to fiercely protecting the mother.
Fiercely protecting the mother.
I want to leave you with a final thought to ponder as you go about your day. Think about the evolutionary trade-off of the human uterus.
Quite something.
The very same biological design that successfully funnels staggering amounts of blood to grow a human life, that incredible vascular basket weave, is exactly what makes human birth so uniquely perilous once that life is born.
It's true.
Our greatest biological triumph inherently carries our greatest vulnerability. Thanks for joining us on this deep dive. We'll see you on the next one.